Hello, good evening, everyone. My name is Annie Benzie. I am the chair of the SSAT Fellows Subcommittee group, and today I'm very excited about our talk. We have an excellent moderator, Dr. Motas Godan, and also an excellent panel of discussants here that also do a lot of liver and pancreas surgery, so please feel free to chime in at any moment. In general, more questions in the chat are welcome, and I'll make sure to moderate them throughout our session. If anyone has any questions, please just at any time, but I would ask for everyone to let Dr. Krasowski get through his research and kind of background slides as well. So without further ado, Dr. Godan, could you just give us a little intro and introduce our talk tonight?
Yeah, perfect. So thank you for the opportunity to be here today and moderate this discussion. My name is Motas Godan. I am a liver and pancreas surgeon at the Mass General Hospital. I trained at Memorial Sloan Kettering, which is basically where some of my interest in this program comes from. Memorial Sloan Kettering have a long-standing program, and unfortunately, as a result of some of the data that we've seen recently, you're probably going to see today, there has been a continued and sort of a regrowth in the interest related to this field. I always tell people, and I actually also tell my patients, that basically, some of the common indications that you're going to see today include some of these unresectable categories where there are sometimes some limited options, and where resection may not be an option. Pump, and now we're hearing more about transplantation are kind of two common options. But there are other indications for pump, and there are also other diseases that it's used that it's currently used for. Having said that, I think without further ado, I'll pass on the baton to my colleague, Dr. Gazovsky. He'll take over and tell us a little bit about pump from his side. And I think my understanding is the aim of this is to try and be as interactive as possible, and we'll maybe minimize the interruptions, but if there are some interruptions that are, we can always take any questions or additional pointers. All right, thank you.
Yeah, thanks a lot, Dr. Godan. I appreciate the time to help us out with moderating this discussion. And I'd also like to thank Dr. De La Fuente, who's my program director, calling in from, currently he's in Argentina, so we appreciate the effort for this presentation. So I was going to talk about hepatic artery infusion therapy for metastatic colorectal cancer primarily. I know Dr. Godan talked a little bit about other indications. That would be a pretty broad topic. So we narrowed it down to metastatic colorectal cancer. My name is Andrew Gazowski. I'm the Advanced GI Surgical Fellow with Adjutant Health in Orlando, Florida. So this is sort of a breakdown of how I think the day or the presentation will go. We've got a case that we'll talk about, and then we'll kind of go through the overview and summary of the current literature that Dr. Godan had sort of alluded to, as well as talk about indications for HAI pump placement and some complications of hepatic artery infusion pump insertion. And then briefly, a little bit about our recent experience here at Advent Health Orlando. We have just started doing this within the past year, so we'll talk a little bit about our experience as well. Just some quick things on metastatic colorectal cancer. There's nearly 150,000 new cases every year in the US. At time of diagnosis, 25% have synchronous liver metastases. 50% of all patients will develop metachronous liver metastases after their diagnosis. It's often the only site of metastatic disease, and it's the most common cause of death. And surgical resection is the only opportunity for cure for these colorectal liver metastases. Liver-directed therapies can be used to maximize response and possibly lead to resection and improved outcomes that we'll get to as we're reviewing our literature. 5-year survival rate for Colorectal cancer is 64%. Stage 4 disease with liver metastases is 14% 5-year survival. So these therapies are helping us improve the survivability in stage 4 disease. So the case we put together is a 59-year-old male with metastatic colorectal cancer. He had a screening colonoscopy that showed a sigmoid lesion and a workup that included a CT scan showing metastatic disease to his liver. He was started on a biologic and FOLFOX chemotherapy in which he completed his regimen. He had a repeat colonoscopy that showed reduction of his tumor in the sigmoid, approximately 20 centimeters from his anal verge. CEA decreased to 5 from around 77 prior to his neoadjuvant chemotherapy. He had minimal symptoms from his colon cancer or his chemotherapy treatment. Medical and surgical history you can see, and no real contributory family history. So here's a preoperative, diagnostic CT scan of his abdomen, focusing on his liver, showing that he's got predominantly right-sided metastatic lesions in his liver. And the title of the talk, unfortunately, kind of answers the question, but I will put it out there for other fellows to possibly chime in. What are the treatment options for our gentleman with sigmoid colorectal cancer with metastases to the liver?
So here in this Felipe from Miami Cancer Institute. So here in our center, we don't have a hepatic artery infusion. So this case would go straight to chemotherapy. The left lateral segments are free of disease, or are they're completely free of disease?
Yeah, it appears that they are.
Yeah.
Completely free of disease.
Yeah. So most likely in these cases here also we would consider some type of radioembolization to the right side and possibly include segments 4A, 4B.
So that's an interesting one that you bring up, radioembolization and Y90. Do you know if there have been any data to support the use of Y90 in metastatic colorectal cancer?
I would not know how to answer that, sir.
Yeah, so there are actually some prospective data. Unfortunately, the Y90 data is a little bit messy, and unfortunately, I think that it's actually been plagued by trial design. And in some of these studies, they've actually included patients who have pulmonary metastases. And so the use of Y90 has not been shown to be associated or result in a benefit of overall survival. But I think that's largely due to trial design more than anything else. It is an interesting one because it probably does treat the right liver while allowing for hypertrophy on the left as well. So I do think that is an unfortunate side effect of this. Let's say that you also...
Yeah, and sorry, Dr. Kunzler, I will say that there is a left-sided lesion sort of right here that I didn't get a great cut on. So, it's, I apologize that he has bilobar disease.
That's okay. Even if a single lesion in the left lateral segment, we'll probably consider Y90, follow that lesion, and maybe ablate it after. So that would not preclude this patient from receiving Y90 in our center, I think.
Yeah, I think there might actually be a couple more, because if you look on that first slice on that top left, there's actually one that's sitting on the left portal vein, or the left hepatic vein there. Actually, it looks like the IVC, and that looks like it's more towards the left lateral sector. And then that third picture as well, it looks like there's exactly right there. You got it. Yeah. So I do think that this is a case of bilobar hepatic metastases. I think if you had the left lateral sector free, the only other thing that I would say is you would also consider a right-sided PVE to try and grow the left lateral sector if that was the case. So Y90 is one option, but a PVE would be another option that's probably more commonly used as well.
Here in our center, sorry to prolong on this, but So we would do I-90, and then 3 months after we'll do the PV and maybe hepatic vein embolization also. But I hadn't noticed the lesions in segment the left lateral in segment 3. Apologize.
I think the important emphasis for all the fellows that are on the call is that the treatment here is systemic chemotherapy. That is the first treatment that would be indicated. Prior to any local regional disease control here, I think systemic chemotherapy is the most important thing. And of course, complete staging, including the chest. Potentially a PET scan in this setting would be helpful as well to rule out any other disease as well when there's this much disease.
Yep, and our patient did have a CT chest that showed no disease in the chest for his further staging workup. So with our patient, we scheduled him after his systemic treatment. We scheduled him for an LAR and hepatic artery infusion pump insertion. The rationale we'll quickly get into for the fellows primarily are liver metastases are perfused by the hepatic artery. Normal parenchyma is perfused by both the portal vein and the hepatic artery. So perfusing the hepatic artery with liver-directed chemotherapy is a more direct treatment with fewer systemic interactions than general chemotherapy alone. So for our operation, an LAR was performed by the colorectal team. An upper midline incision is used for hepatic artery pump placement. We always do a cholecystectomy with our hepatic artery pump placement, as well as a portal lymphadenectomy. We identify the common proper GDA, left and right hepatic arteries. We found that he had, luckily, fortunately, I shouldn't say luckily, he had a normal caliber GDA. Also perform an extended Coker maneuver. Proximal and distal control of our GDA is obtained, as well as the common and proper hepatic arteries. We then prep the pump and create a pocket in the left abdomen to insert the pump and suture it to fascia. The arteries are clamped and the arterotomy is made in the GDA. We place the catheter to end at the takeoff of the GDA, flush with the takeoff of the GDA. We secure it in place with 3O silk and 4O proline. We then flush the pump with heparin and methylene blue dye. In doing this, we confirm that both lobes of the liver are perfused without any leak or extra hepatic perfusion. And then we close the fascia and the skin. Here's a representative image, not from our particular case, but I believe this is an earlier one that Dr. De La Fuente performed, showing insertion of the hepatic artery infusion pump catheter into the GDA with both the common and the proper hepatic arteries being controlled. Here is the pathology from our procedure, showing that he did have 2 metastatic lymph nodes in his colon resection and benign lymphadenectomy from our benign tissue in our lymphadenectomy performed for the hepatic artery infusion pump. Post-op day 1, we follow the ARS protocol with our colorectal surgeons. On post-op day 3, we give a technetium-99 liver perfusion scan via the hepatic artery infusion pump. It showed heterogeneous uptake in the liver with no extra hepatic uptake. He was discharged home on post-op day 4 after infusing heparin in the hepatic artery infusion pump. So he's had follow-up with surgical oncology as well as medical oncology with a treatment schedule of filling the hepatic artery infusion pump every 2 weeks, alternating with FUDR and heparin. He resumed his FOLFOX treatment. Was resumed on the second refill of his hepatic artery infusion pump. Surveillance CT scans have been performed with a decrease in his tumor burden. So this is imaging from his technetium-99 liver perfusion scan, showing that there is bilobar uptake of the technetium-99, indicating that we have good perfusion of the liver, as well as no uptake in any of the extrahepatic areas. A restaging or a surveillance CT scan that was performed, I believe it was after his third treatment of his FUDR in his hepatic artery infusion pump, showing the liver metastases are responding to treatment. You can still see a few in the left side here, but it appears that the left side is also responding to infusion treatment. I included a few slides of the catheter inserting in the GDA, as well as the pump itself. So now I just sort of want to talk a little bit about the literature and sort of a quick review of the literature on hepatic artery infusion pumps used for colorectal metastases to the liver. This is a study performed in the late 70s, early 80s that used different chemotherapy agents for hepatic artery infusion. And they measured hepatic extraction and sort of drug clearance to estimate the hepatic exposure with hepatic arterial infusion, and FUDR was the drug that had the highest hepatic artery liver exposure with hepatic artery infusion. This is another early study, hepatic artery infusion toxicity and results in patients with colorectal metastatic carcinoma, done in the mid-80s. It's a small study that was done in 84 that showed partial response with liver-directed therapy in 52% of patients that were previously untreated. And it showed a partial response in 17% of previously treated patients. The unfortunate piece of this was that there's severe GI toxicity in 46% of the patients. And this has led to, or the consideration of the extended Coker maneuver, as well as the cholecystectomy and portal lymphadenectomy to minimize the extrahepatic flow of this chemotherapy. Another study that was performed, the calbg trial, was a phase 3 trial that compared hepatic artery infusion versus systemic therapy as a first-line treatment. It was 135 patients at 9 centers with unresectable colorectal liver metastases in less than 70% of the parenchyma. This was done in the late 90s, early 2000s. So the treatment was hepatic artery infusion with no systemic therapy versus systemic treatment for metastatic.
So let me just stop you there for 1 second before you move on to the results. Can any of the fellows here guess what the result of this trial could have been? So you've got HAI versus systemic therapy. So outcomes of overall survival, what may you expect to see and why? A little bit of a nuanced oncology question.
Annie, you want to pick on somebody?
Oh boy. Let's see.
So I think Dr. Kunzer is actually the only fellow on this call, but
Good,
if anyone
so I'll have to reply then.
We've got Dr. Likes on too. We've got Cecily Likes.
Oh, Cecily. I didn't realize you changed your name on here, so Cecily, if you
Sorry.
wouldn't mind.
Yes, I'm here.
The tradition of our fellows getting married, Dr. Benzie.
Yeah.
Congratulations.
So, I mean, the way that the question's being asked, I'm assuming there is a difference between the two types of therapies. As far as overall survivability, I would assume that hepatic artery infusion probably has better overall outcomes than systemic therapy as far as initial therapy and side effects, but I would think that systemic therapy may have a long-term survival benefit.
Yeah, I think that's kind of what I'm getting at, except I would just also add that the problem with giving therapy to the liver only is you're excluding everywhere else, right? So you're not protecting the lungs, for example, from disease. Whereas the systemic therapy, it's a more complete global picture of treatment, right?
Right.
So
That's why I'm thinking that overall survival benefit would be higher in systemic therapy.
in systemic, okay, yeah, that's what I would have gone with as well.
Yeah.
That's what I would have gone with as well initially when I first read about this study.
That's not the right.
Yeah, so good.
Yeah,
We're in
yeah.
agreement. Yeah, good.
Yeah. Yep. Surprisingly, the progression-free survival in the hepatic artery perfusion was 9.8 months versus 7.3 months, which is a little bit counterintuitive. And I think that's what Dr. Kadan was sort of getting at. And the overall survival was slightly better in the hepatic artery infusion pump group versus the systemic therapy group as well, which is, again, a little bit counter intuitive, and that's probably why he brought it up.
Yeah, so the hepatic progression-free survival you'd expect to be better with the pump because you're treating the hepatic, right? So that's expected, but it's the other one that's not as expected when you first read about this study. So what does this tell you? What does this allow you to conclude potentially, which now we're starting to understand in this era, in 2023, we're beginning to see this. So if survival is better with pump over systemic therapy, what does that tell you? Does that allow you to conclude anything? The same person who answered the first question would be great.
Sorry, I'm having some technical difficulties over here.
No
So
problem.
I would assume that would show you that the progression of disease is actually from the original source versus systemically. And so if you're treating locally, you're not only preventing local recurrence, but then later metastasis.
Yeah, yeah, and I would actually say that it probably shows you that liver metastases are actually the most lethal entity here, right? So if you are directing that dose of chemotherapy via pump and getting that kind of improvement in overall survival compared to a systemic one, that maybe liver metastases are more lethal than lung metastases, which, by the way, is turning out to be a thing. All right, so we actually think that the liver carries probably the most lethal burden.
So just a question for you, Dr. Kadan, because intellectually, it would seem to me that Y90 would have a similar effect. Now, when you looked at Firefox Global, which was Y90 actually early in the treatment, and having looked at those scans, these patients were not liver predominant patients. I mean, they have a lot of extrahepatic disease. There was great liver disease-free progression improvement, but not overall survival benefit. What are your thoughts between those two entities?
Yeah, so I think that whereas I'm saying, so that's a great question, because whereas here I'm saying that the liver burden is more lethal than the lung burden. How is it that when we've included the lung burden, we didn't see that positive effect? And the problem, I think, and this is what I think happened in these Y90 trials, is the patients were not selected at all. There was no attempt at selection, and actually the lung burden was probably too excessive. So my statement comes with a caveat that if you have two lungs that are absolutely full of metastases, you're probably not going to see that benefit by treating the liver. Whereas if you have, for example, solitary or few or dormant, slow-growing lung metastases, you probably will see that benefit more likely. So I think, unfortunately, the IR literature failed to select patients at all. As a result, we've ended up seeing that failure to distinguish overall survival between the arms of the studies.
And so this is a summary of the findings that we have discussed already, saying that, hepatic artery extrahepatic progression was worse on the pump, was worse with the pump, not surprisingly. But the data that I think Dr. Kadan already talked about suggests that controlling hepatic tumor burden is what drives survivability in these colorectal metastatic patients. Here's another study that was done. We're sort of working along a timeline of, okay, we know that it works for, potentially initial treatment, but now let's say we do hepatic artery infusion with systemic therapy versus just hepatic artery infusion versus systemic therapy alone. And this was as a second line treatment. And this was a case control study ending in 2014 in unresectable colorectal liver metastases. All of the patients in the study received first line chemotherapy. On average, there were 15 tumors in the liver when they included their patients. The outcome was overall survival. And in the second line therapy, it's showing, they found again that hepatic artery infusion and systemic therapy had improved survival. Again, showing that if we can treat the liver metastases that are driving mortality, we can improve overall survival.
There's a question in the chat. In that study with both, were the treatments given together or separately?
So in this study, it was hepatic artery infusion of FUDR and then systemic chemotherapy concurrently together.
Yeah, and it was actually based on that last calbg study that you saw that now we give the treatment concurrently. And actually, typically we'll combine FUDR with FOLFIRI. So you're replacing the oxaliplatin with irinotecan.
Yeah, and I think these are all done before the improved chemotherapy treatments were around. So we're combining the FUDR with better systemic therapy.
Correct. Modern systemic chemotherapy came in about 2006. A lot of these studies started in the late 90s.
And could you explain the rationale, Dr. Kadan, for the irinotecan as opposed to oxali?
Yeah, so I think the concern that you have mostly with pump is the complication of biliary sclerosis, and the concern, I guess, must be in medical oncology hands expected to be higher with oxaliplatin than irinotecan. The problem with biliary sclerosis is it rarely happens. When it happens, probably 1 to 2% of the time, it's probably not even that high, but that's kind of what I quote patients up to sort of 1%. It is a very concerning problem when it happens, and you really need a great medical oncologist to work with to minimize biliary sclerosis. So they have to dose reduce appropriately. They may have to pull back on the systemic chemo. They may have to give additional steroid because it really can be an irreversible entity. And I think, if I'm not mistaken, the first transplant to ever happen for metastatic colorectal cancer in the US was actually to transplant for biliary sclerosis rather than the tumor per se.
And so this is another study looking at hepatic artery infusion for metastatic colorectal cancer. There's refractory to all standard chemotherapies. It was completed in 2014. So unresectable colorectal liver metastases, which progressed on systemic therapy. Their patients were recruited, and liver-only disease were 57 patients. Extrahepatic disease was 54 patients. Most of them were with lung metastases as well. Lymph node metastases outside of the resection area for colorectal cancer was 49%. So this is showing us a waterfall, showing that the majority of these patients with hepatic artery infusion pump had a stable disease on follow-up, or reduction of disease on follow-up. And this median survival, I'm sorry, I have cut things off. A median survival was 20 months in these patients, which was an improvement over the 6 or so months approximately with disease advancing on systemic chemotherapy. Another study that has been recently completed, 2018, was a phase 2 trial, combination of hepatic artery pump and systemic chemotherapy for unresectable colorectal liver metastases, sort of long-term results and curative potential. So this study looked at hepatic artery infusion pump with chemotherapy and the potentiality for resection to be possible. And so median follow-up with this was 81 months. So the response rate was very good, pretty much in line with the other studies that we've talked about. So chemo-naive patients, the response rate was better than in previously treated patients. And this is the hepatic artery infusion plus systemic therapy. 52% were able to convert from unresectable to resectable. And the median overall survival in these patients were 38 months. If you're chemo naive, it was 77 months, and then previously treated for refractory metastatic disease was found to be 30 months. So this study showed that if you're treating the liver as well as systemically, we can get the liver disease burden down to safe resection.
So I just want to say something. If you could just go back to that slide for 1 second.
Yep.
Just ask people just to take a look at these numbers and imagine what it is that we're talking about here. Okay, so we're talking about people with unresectable disease burden, who essentially, for all intents and purposes, say even 20 years ago, had no business being alive, right? And we're talking about a group of patients who've been treated already in the refractory arm with chemotherapy and failed the first line, essentially, right? And so there is nothing that could give you this type of survival. Remember, your comparison in unresectable disease is otherwise systemic chemotherapy at best. And you will get some median survivals of 2 years and rarely up to 3 years. But here we're talking about median survival of 77 months. That's 6.5 years for 50% of patients to be alive who initially started off with unresectable disease. And even in the previously treated of 30 months. Go ahead. Thank you.
Yeah, thank you. And then the big point from this paper that we talked about was conversion to resection. And so if you're able to convert to resection within 12 months of treatment, the 5-year overall survival jumped up pretty dramatically, 63% 5-year survival versus 13% in those that were not be able to convert to resection. This also just sort of further demonstrates that surgical resection is the curative option for these patients with metastatic colorectal cancer.
And again, in the non-resected arm, 5-year overall survival of 13%. So I remember we asked Dr. Kemeny this, and we said, well, what about the patients who don't convert to resections? He said, well, those patients still live longer, right? So if you think about these patients, rare to see 13% of people living without any form of treatment except for systemic chemotherapy up to the 5-year mark. 13% here.
There's a question in the chat too. Are there any subgroups that don't respond as well, i.e. those with mets other than liver?
Well, typically those patients are excluded from placement of pump. So it's a good question. I don't know the answer to that, therefore, because typically when we find extrahepatic disease, we would not consider that type of patient for pump chemotherapy. Now, again, I think it just all depends where the field goes. But if we really start to believe that hepatic mets are the most lethal, then the answer is maybe that those patients could start becoming, included. And we are learning this from the literature. We see this anecdotally with our pancreas cancer patients who have lung-only mets who are actually living longer than you would expect, and so on. The question really will be, are there any molecular subtypes, genetic mutations, and so on, of patients who do not respond as well, including KRAS and BRAF and things like that, ultimately.
So, Dr. Kadan, one of the criticisms of this work has been that the patient selection is obviously very, very skewed just by the fact that this was done at Memorial, and just the ability to travel and the means to travel is obviously a big issue. What are your thoughts with regard to that?
Yeah, so on the selection specifically, I always say that's a great thing. We really should be selecting the appropriate patients for the therapies, and actually selecting the patients who are going to benefit, and not including those who are not going to benefit, not just from a diluting the data perspective. That's not the reason to do it, but you really want to offer the right therapy for the right patient. The second thing that I would say is that the Memorial experience has really been fantastic because of the investment that they've had in terms of the personnel and interests in it. But now we are seeing these programs start to pop up everywhere. Now, I will say that there is one paper, I don't know if you bring it up, the JCO paper by Bass, I think it was in 2017. But what Memorial did was they went back and looked at every single patient who got pumped versus those who do not or did not. And what they were able to show was that there was an association with improved survival in every single category they examined, including the low-risk patients with low CRS scores, with solitary liver metastases, with no negative primaries. And so that paper really clinched it for kind of these centers to start popping around the country, including ours. We've just started doing pump in our program now as well. But you just presented some UPMC data there, and I think that there are data emerging from other centers. And the great news is we now have a pump consortium that is actually made up of different institutions, and we're setting up a clinical trial together jointly outside of Memorial. But just to add that there are also some Canadian and European studies that would support the data that we've seen so far. Having said that, I completely agree that the bulk of the data has come from Memorial, and it has been criticized for that.
Yeah, no, I just want to say that I totally agree with patient selection, but I don't agree with patient selection based on ability to travel.
Yeah, and that's a very important point, because it's also on us to be able to minimize these disparities. It is a multifactorial problem, though, because also it turns out that patient preference for travel is also very heavily interlinked to that, and actually very much linked to socioeconomic data as well. Very complicated topic, and something that I have a huge interest in as well.
That's why I brought it up, Dr. Kadan.
Yes, sir.
And so I think we've touched on this a little bit. The indications for hepatic artery infusion pump for colorectal metastases is unresectable colorectal metastases. So involving three veins, both portal veins, IVC, or leave less than 2 adequately perfused segments of the liver. And so it's a pretty broad indication. I suppose the other indication we need to put in is the ability to place and manage and have enough resources and or support for patients to be able to manage the hepatic artery infusion pump itself. We are converting patients from unresectable to resectable disease with these hepatic artery infusion pumps. I wanted to briefly touch on some of the complications. Dr. Kadan mentioned sort of the biggest one the most concerning, which is the biliary stricture, biliary issues. And there's about 3% is sort of the number that's been floated around there. And I think it sounded like that's what you talked about, Dr. Kadan, is about 2 to 5% have this biliary stricturing that can be very, very problematic. There's other complications that are involved with arterial manipulation, hemorrhage, thrombosis. There's also extrahepatic perfusion, and that's the primary reason why most institutions get the technetium-99 study prior to infusing the pump with chemotherapy. Incomplete perfusion is a problem, and that's another reason why we try to do the studies prior to infusing with chemotherapy. Pocket infections, hematoma, pump migration are all other complications that happen and are generally managed fairly well without losing the pump itself.
And just to mention, by the way, the biliary sclerosis, interestingly, you can see that with Y90 as well. I had a patient who got 2 doses of Y90 for HCC metastases and had crippling biliary sclerosis. Actually, I think that we completely treated his HCC, but he suffered with 2 years worth of biliary interventions, including stenting and replacement of stents and recurrent cholangitis and things like that. It is a vexing problem when it happens.
And this is just some imaging showing the complications, seromas, hematomas, dissection of hepatic artery, biliary sclerosis, which is the most concerning, stenting and restenting and re-ARCPs, which is difficult for patients and very difficult to manage. And at Adjutant Orlando, we've been doing this for just about a year at this point. So we're getting to the point where we're hoping we can have some of our patients being treated to resectability, and we're hoping that our candidate that we presented today will eventually be able to have resection of his colorectal metastases. I'm actually glad that Dr. Kunzler talked about what other forms of treatment for liver-directed therapy. I know that is not in the title of the talk or the main direction for our talk, but there is transarterial chemoembolization and selective internal radiation therapy with Y90. And it sounds like down in Miami that the internal radiation with Y90 is an option. And both modalities, just like the hepatic artery infusion pump, have been studied with colorectal cancer, and it showed improved response rates and even survival in the studies that have been performed. There's some recent studies, I think Dr. Kadan talked about, that the Y90 has not been as effective as a first-line treatment for colorectal metastases. We did find a very recent study showing that overall conversion rates to resection were highest using the hepatic artery infusion pump compared to hepatic artery therapies with the TACE and the Y90. And unfortunately, there's no real great studies directly comparing the liver-directed methods. And so there's no real guidelines. NCCN says that in the right circumstance, at the right institution, we would recommend using liver-directed therapy for metastatic disease for colorectal cancer.
So, Dr. Kozlowski, I just wanted to bring up, there is this one retrospective paper from Pittsburgh looking at Y90 compared to HAI. I don't know if you're going to cover that, but it was a very unequal set of patients, because obviously the ones that were able to get HAI and undergo general anesthesia open at that time would get the HAI, and those that were unfit got Y90, and they found that there was I believe, if I remember right, there was a benefit to HAI over Y90, but they were very unequal groups. Do you want to comment on that?
Yeah, that I did come across that same study, and it was the hepatic artery infusion. The patients were sort of self-selected, like you mentioned, to be able to undergo general anesthesia. It just sort of separated the patients to, are, I don't want to use more hardy, but they are more likely to have a prolonged survival just because of the fact that they're, in better condition at the time that it was performed.
Can I just address a couple of great questions by Dr. Jayaraja there that he's asking? So the last one was about FOLFOXIRI. I mean, that is just a terrific question for multiple reasons. So number one, when using pump, it's difficult to justify doing the triplet regimen because that could increase the rates of biliary sclerosis. Number two, when trying to do FOLFOXIRI first as a test of tumor biology or to treat unresectable disease, I think that's completely reasonable. And then if proven that tumor biology is reasonable, to move to pump and then convert to a doublet regimen. Number three, how does FOLFOXIRI compare against pump in a head-to-head? And the answer is we don't know, but that would be a great clinical trial. We do know that calbg trial looked at systemic versus pump, but it wasn't modern era systemic chemotherapy, and it certainly was not the triplet regimen. And the question is, how does it compare? I don't know. My guess is that pump does better, but I don't know the answer to that. And that would be a great clinical trial to answer. The reason I say that I think pump would do better is because of the data in the unresectable setting, that phase 2 that you saw, the numbers just appear to be much better. Again, you might say that's a different selection of patient population. Totally agree. I can't argue with that.
So I just wanted to ask you, Dr. Kadan, is there data on safety of pump after triplet therapy? Because it seems to me that you're hammering the hell out of this liver with both irinotecan and oxali.
Yeah, that's a great question, and I don't know the answer to that. I can tell you that I've got a couple of patients right now who are getting triplet therapy and are due to come and be evaluated for pump after. I think as long as you're not giving them concomitantly, and I'm pretty sure there might be an increase. You would imagine that the safety profile must be a little bit lower. I mean, it would just make absolute sense that that be the case. The good news is we do know that a lot of these chemotherapy-associated liver toxicities tend to be reversible with time. And so typically what I do for any patient who's had FOLFOX, FOLFIRI, or FOLFOXIRI is I tend to wait 4 to 6 weeks before taking them to the OR to allow the liver to recover some of its function. And so I'm sure the answer is going to be somewhere in between, where it does recover, but probably not completely, and it probably does add to the sclerosis rates somewhere down the line.
And sorry to sort of bring up some controversies here, Dr. Gazowski, but I just also wanted to ask you and Dr. Kadan, post-pump, is there data on margin status? Because, as we think about for, neoadjuvant therapy in pancreas, sort of the MD Anderson diagram of sterilizing the edge of this tumor, do you think we still need the same margins post-pump?
I'm happy to try and answer that, but I think that's also a phenomenal question. I mean, clearly we're dealing with some very nuanced questions that are, I mean, they're just perfect. So what we learned about systemic chemotherapy is that R1 margin probably doesn't matter as much, believe it or not, in the setting of neoadjuvant. And we saw that at the MGH experience that Cindy Miller published. And I think that the reason that the Paul Bruce study, when it looked at R0 versus R1, showed no difference is there may have been some neoadjuvant patients in there. I don't know, I can't remember. But I do know that the margin did matter in the Memorial study and the MD Anderson study. So I think if you're giving neoadjuvant, it probably doesn't matter as much. Now, I'm not saying go ahead and resect with a positive margin because you gave neoadjuvant. That's the problem with the messaging, and we have to be careful. And I would say that based on that data, I would think that with pump, it probably matters less. And we're also seeing that with pancreatic cancer, for example, patients who got radiation, where R1 probably doesn't matter anymore. Now, again, this is R1, not R2 data. Cutting through tumor is a different element altogether. That's a different conversation. But that's a great question.
No, thank you so much. And, I think just for the group to hear this discussion, I think this is amazing and that's why I have a lot of questions. I'm so glad Dr. Kadan has the answers because I'm like full of logic, but no data, unfortunately. I think the also understanding the difference between a vascular margin and a hepatic margin is really important because those seem to be different for us. So just for the group, we're at questions and comments. Great for the group. I think that this is really important, and I think Dr. Passeri and Dr. Ross, you're on now. I think the aim is not to go for an R2 margin, but if you think you can get complete tumor destruction or resection, then it's reasonable to push the envelope, right?
Yeah, I think that's definitely true. I mean, this is a fantastic meeting where I'm kind of scribbling down questions as quickly as I can because a lot are coming up. I think with us, we're actually in the nascent stages of trying to build a hepatic artery infusion pump program. We're along with Mount Sinai, who's well ahead of us. We're up in northern New Jersey, for those who aren't familiar with Valley, and what we do have is a fantastic IR department in Y90. We get those patients done quickly. We're slick with resections. We can do some nice ablations and we can get Y90 done. What we can't do for logistical reasons mainly is get our patients pumps. Now we're starting to work with New York and getting them pumps, but as far as resections go, we're focused on getting R0 resections if we can and being aggressive if we can. But yeah, I think I feel better about incorporating systemic therapy as far as margin considerations, as you mentioned. While I'm speaking, just one real quick question is, where the data stand now. I mean, I had a patient this week who he's got kind of the not so much unresectable cancer, but the frustrating cancer where we keep doing these, resections and ablations and it keeps coming back. And he's always been resectable and he's been doing well for years. Like, when do you start considering embolic therapy? And my gut instinct for logistics is just to do Y90 or TASE because we can do that much easier here. Is a pump that much better? And should we really make the effort to get him a pump?
Dr. Kadan, I mean, I would love to study in well-matched patients of Y90 compared to pump because we just don't have that study.
Yeah, that's exactly right. The other thing that I would say is actually the original data, let's not forget, that came on pump was in the adjuvant setting. So the first New England Journal of Medicine paper by Nancy Kemeny was the adjuvant setting. And then she went back and looked at that after 10 years of median follow-up to actually see if there was still a difference. Now, of course, the problem is as the patient population got smaller and some of those patients died, the study was then underpowered at 10 years to actually detect differences. But there were still some differences in kind of an hepatic progression-free survival and things like that. So this is exactly what we're talking about here, which is hepatic progression-free survival. In fact, those are the patients who may have benefited the most in the adjuvant setting from getting a pump initially. In terms of recurrence and re-recurrences in the liver. Now, at the end of the day, if the patient's doing well and living for years, I think basically all options are a go here. And tumor biology has clearly established itself to be a great one in a patient who's lived for years with multiple recurrences. The problem is all these therapies get more difficult after repeat interventions. So Y90 gets harder, repeat surgery gets harder, and everything just progressively just gets worse with time.
Dr. Jairaj has another question. Do you do the HI adjuvantly to LR?
Yes, we will. So just again, for full disclosure, our program currently is that it's in an infant stage compared to the MSK program. I mean, I'm just happy that we're able to finally open it here at MGH. It took a lot of sort of logistics and things like that to get it going, and the COVID, and then the company got sold and things like that. So it was actually pretty tough. Right now, I'm trying to do it only for unresectable patients who are easy with conventional anatomy. We're just trying to get up and running, basically. But yes, adjuvant patients are clearly indicated. And then ultimately, don't forget cholangiocarcinoma, as I mentioned, and also some HCC patients. And I think that there are people starting to experiment with looking at things like pancreatic mets and other mets here, and whether or not you could use it prophylactically to prevent the development of mets in the liver. So the field has a lot to go, and that's not even to include new agents that you could include in the pump. But for me right now, the key population, I think, is the unresectable one. And I'm happy to share an additional thought on that in a moment.
So Dr. Kadan, some of the patients hate the size of the pump, and Nancy Kemeny tells them that they can't run or exercise aggressively. What are your thoughts on that? From
Yeah,
a
it's
quality
tough.
of life standpoint.
It's tough. So this is why in the resectable and the unresectable population, it's easier, all right, because the reason is you have buy-in from the patient. So the one thing that we've learned about pump is it's an option, right? So I give a talk on unresectable colorectal liver mets, and I will tell you there is not much that's harder out there than telling a patient you can't do anything for them, or you're going to keep going with a systemic therapy, and then they'll say, and now what? And then there's no answer to that, right? There is no end game in systemic chemotherapy. Whereas when you then start talking about things like pump, conversion to resectability, longer survival, there's also transplantation. And I think that these are options. And that's why we have to be very open-minded about them, you know. Now, transplant people say a very small number of people who get there. That's correct. They are currently a very small number of people. But as organ availability increases, this will become a more feasible option. And as we broaden the criteria, whether or not we should, there's a lot of debate about that as well. So my point that I'm trying to make is you're talking about a desperate population, frequently young patients who have unresectable disease. And in that patient population, patients are willing to go through the fact that they can't sit in a hot tub or can't run, or they have a hockey puck sized device sitting in their abdomen. Because, you know, really they want to survive and be with their families and have some longevity and be able to continue their careers. And so these problems start to get a little bit diminished. I'm not diminishing them. I'm just saying that the patients to them will feel that these problems are diminished compared to what they're facing in reality in the unresectable setting.
Dr. Passeri also had a question. It's actually that this case study is interesting too. Any thoughts on concurrent colectomy and pump placement? Does this pose an infection risk? No, Dr. Gazowski, is that something that you routinely do?
Yeah, I can speak to that a little bit. At Advent Orlando, we are very frequently doing concurrent colorectal resection and hepatic artery infusion pump. Of the dozen or so cases that I've been involved with, probably 80% of them or so, 3/4 of them are concurrent resection and pump placement.
Yeah,
Thank you.
With very few, pump infection concerns. There was one person that had an abscess after his colon resection that was treated with a drain, and we ensured that we were keeping it away from the hepatic artery infusion pump. So I don't want to say we were fortunate, but we caught it early and controlled it early.
I do worry about it a little bit, I will say, but fortunately, it's very uncommon, and those procedures are done concomitantly.
Final questions, comments, concerns? It's a great discussion. I appreciate everyone. Okay, so with that, thank you all for joining us this evening. Our next Grand Round series will be on Monday, April 24th. The topic is internal hernia after Roux-en-Y gastric bypass. Thank you all for your spirited discussion. If anyone has any questions, I'm sure Dr. Jayaraja are bubbling. I'd like to start a research project around this very topic. Just feel free to reach out to anyone too. Some of the same questions. Okay. Thank you so much, Dr. Kadan, Dr. Gazowski. Great job, and everyone else have a great night and see you next time.